Hi, my name is Katie Armstrong, and I'm here to present my capstone project for the Wilson School of Nursing at Midwestern State University. The title of my capstone project is The Challenges in Detecting Posterior Strokes in the Emergency Department. The objectives of my project are to identify the common signs and symptoms, to recognize atypical presentations of posterior strokes, to highlight the challenges in identification, to understand the importance of early recognition, and to introduce an extended stroke screening protocol through a proposed plan. The purpose of this capstone is to address a critical gap in healthcare and to understand the clinical significance, the diagnostic complexity, the knowledge gaps in healthcare professionals and nurses, the impacts on treatment decisions, educational needs, patient outcomes, and long-term prognosis through technology and innovation. The clinical significance of this capstone project is that posterior stroke patients are misdiagnosed twice as often as compared to those with anterior events. Posterior strokes present with subtle symptoms. They're not your common stroke-like symptoms. So that presents a challenge, leading to delayed or misdiagnosed cases, and also hampering the timely initiation of crucial interventions impacting patient outcomes. Emergency nurses are often the first clinicians to assess patients with stroke-like symptoms. Therefore, we as nurses need to be able to recognize patients presenting with acute posterior stroke symptoms. Just to put in perspective of how significant this event or this project is that posterior strokes represent 20% of all ischemic strokes, and that's by the CDC themselves. Also, annually, posterior strokes in the United States, about 160,000 people will suffer from one of these events. My PCOT statement is that in patients presenting with neurological symptoms, how does the implementation of an advanced stroke screening tool, like an advanced NIHSS, compared to the current stroke assessment tools, improve the detection of posterior strokes in the emergency department? So just to give some background, you may be familiar with the BFAST or NIHS screening tools. Those are what are most commonly used in hospitals nationwide. And throughout this project, I learned that most researchers and most people that do evidence-based practice on these stroke screening tools have shown or proven that those current stroke screening tools being used are biased towards anterior stroke events. Again, my literature review through the MSU Library Database, PubMed, and CINAHL, I found more than just 9 articles, but the 9 articles that I use consistently report that those stroke screening tools that I just discussed are biased towards anterior strokes. So they have proven that it underscores the significance of posterior strokes and that implementing an advanced stroke screening tools enhances its validity and relevance in implementation. This evidence supports that a stroke screening tool is a reliable assessment of posterior stroke symptoms within the current research. I was able to just to pull out some highlighted areas that I thought that would be worth sharing that show the significance and use of research that we found to support this evidence. So this one article has said that the post-NIHS screening tool, which is a different advanced screening stroke tool, showed higher accuracy than the current NIHSS screening tool. The modification of screening tools, stroke scales, and extended protocols are suggested approaches to the solution. Utilizing the current stroke screening tools have a higher probability of bad functional outcomes for patients with posterior stroke events. So the extended NIHSS could improve the sensitivity in posterior strokes by adding specific elements to the existing items to explore the signs and symptoms of posterior strokes. So what this means is that whenever a patient presents to the emergency department and we use a BFAST or an NIHSS screening tool, and it's an anterior event, they will significantly score higher on these stroke scales, leading to a faster initiation of stroke code activation or initiation of life-saving interventions, There's something called door to needle if they need TPA or if they need a CT. Those patients are going to be initiated through code fast protocols faster than those with a posterior event. If someone presents with a posterior stroke event with those subtle symptoms that we mentioned, and how subtle they are, they will significantly score lower on those current stroke screening scales, leading to a delay in care. That's why if we implement something that is a little bit more extended, that it's asking other questions, not just the basic be fast questions, then we can capture all those symptoms so everyone can equally have healthcare equity and be able to get to those life-saving interventions. So my proposal plan is that through analysis, we will analyze the current stroke screening tools and see where we can add those specific elements if we do want to keep it the same, if we want to just extend the questions that we're asking, rather than just like last well-known, balance, face, anything like that. That's where we'll do that. We'll analyze those current stroke screening tools. We'll also modify the current stroke screening tools to include posterior stroke symptoms. We'll provide education for nurses in the emergency department, healthcare personnel, our medical administration. We'll do that through online modules, continuing education, any new hire employee orientation, and through the stroke committees. We will implement that through the electronic current assessment tool system. So whenever we plug those scores in, it'll actually populate a score like it does now, but it'll include posterior stroke symptoms. And we'll compare data before and after. So how will we get this information to people? So we'll use continuing education courses. We will try to get published in the Emergency Nurses magazine. I think that is a good tool to reach a broader audience and people that are invested in their nursing practice. We can use unit-based education meetings and those committees that you see throughout the hospital. We'll do online training modules, hospital-wide internal communication channels, whether your hospital uses emails, Teams, however it is, that information will be relayed to the staff, and community education programs. I think that it's important that people realize stroke symptoms like we put that out in the community, but also those other symptoms. It might not just be unilateral facial droop. It could be both sides. It might not be just the dizziness or the confusion. It could be vomiting. So I think it's important that the community also receives education programs in order to get their loved ones or themselves to a hospital for timely initiation. So how will we implement this? So through stakeholders, which will have the ED management, the nursing staff, unit-based educators, physician leaderships, all of those people will be invested in this because they'll want to improve patient outcomes and will optimize resource utilization. So something that we see at the facility that I work at is that people present with these symptoms, right? We initiate code fast immediately, but it's not one size fit all, but it doesn't encompass just stroke symptoms. It kind of brings in a little bit of other diagnoses that could happen. So if somebody presents with dizziness and confusion, we initiate code fast or the code stroke protocols. Well, that could be an electrolyte imbalance, or that could be because they missed dialysis. Like, we are trying to optimize resource utilization by capturing specific stroke-like symptoms in order to allocate our funds, allocate our resources to where they're best being utilized. We will also use incentives for compliance. So our stakeholders will be able to receive incentives for meeting the metrics to improve patient outcomes. We'll use quality improvement programs. We'll measure outcome metrics. So through like chart reviews, we'll be able to see, okay, this person presented at triage. We use the regular BFAST stroke screening tool, and they were, needle to or door to needle within so many minutes. And then we'll see the people that uses the extended NIH scale to see how their initiation happened as well. And we'll be able to compare the events, anterior, posterior strokes, and we'll be able to look at which stroke screening tool had the best patient outcome or the fastest initiation of a stroke protocol, stroke code fast, anything like that. And we'll be able to use electric charting to data capture this information. The evaluation of this is that we'll be able to review and compare data. We'll define outcome metrics. We'll utilize chart review as mentioned for both stroke scales with the results. We'll assess proposed measures. And the hope is to decrease the incidence of misidentified posterior strokes. So in summary, recognizing the profound implications for patient care and addressing critical gaps in timely diagnosis, we'll have a deeper understanding of the subtle symptoms and standardized assessment tools, the implementation of enhanced education for nurses in posterior stroke assessment, and we'll have proficiency in the use of the extended NIHS scale. So far-reaching impact will have quicker, more accurate identification, minimizing delays, and reducing misdiagnosis risks.